As I mentioned before, it was created in 1965 and spread among Black health professionals that consider that racism exists because we experience it on a daily basis. So a related concept with Dr. Pierce, your response to microaggressions is micro-resistance. So you have to engage in micro-resistance, which includes personal or cultural protection response, sort of like what I've coined PPR, personal protective resiliency response. And PPR is internal, it's an inside job. So personal protective equipment, just like your masks and your vaccinations with COVID, it's a psychological immune system that you develop, and you recognize racism in all its variants, beliefs, and practices, and assume that there's a pandemic of racism. Locally, because this is the Eugene-Springfield branch of the NAACP, and Oregon is like a southern state in the Northwest, and it is a perfect learning laboratory for studying institutional systemic racism from the inside. So in Eugene, Racism in Medicine, Lily Parker Reynolds, who recently had a Black Cultural Center at the U of O named for her, still alive, she was born to Sam and Maddie Reynolds at Sacred Heart, which is now Peace Health, and she was born in the late 40s. Her birth certificate written out at the hospital reads she was white. Now, she's my color. Her parents are my color. In no imagination is she white or even close to white. So that the hospital figured that they could kind of hide that fact bureaucratically. And what was happening in Eugene at the time, Black people could not live within the city limits of the city of Eugene. They could not legally buy real estate through an agent. They could not apply for a bank loan. All those things were legal discrimination, illegal for them to do. A real estate agent could lose their license. So Sam and Maddie Reynolds were business owners. They had money, but could not live within the city limits. So racism, medicine was segregated. Healthcare was segregated. So many Black people were born at the Eugene Clinic, which is now public student housing. So even when systemic racism is the norm, what I've done here is inverted Abraham Maslow's hierarchy of needs model, because what he did is he developed that model studying the Blackfoot Nation in Montana on the reservation. He participated in their ceremonies, their rituals and things like that, and observed them in social interactions, observing racist interactions when they went to white shop owners and experienced racism. And this is during the Depression era. He reasoned that the entire Blackfoot Nation was self-actualized while experiencing racism. So totally self-actualized. And basically they inverted his model where even though they were in poverty, they took care of the tribe's entire physical needs and all the other things that float. So his model was kind of inverted with the Blackfoot. But of course, you don't hear about that in psychology school unless you know Blackfeet, like I do. So they're basically they had basically taken notes and they are in the process of publishing that. So there are signs and symptoms that show that you can survive and thrive in the midst of systemic discrimination and be able to offset somewhat the effects of discrimination. So there are some helpful constructs coming out of Black and intersectional psychology. So racism as a disease, like alcoholism, first developed in 1965. Racism as a co-occurring disorder, that means an addiction and a mental illness together, because many racists commit racist acts under the influence of methamphetamine or alcohol and become addicted, and that reinforces some of their beliefs, which are like schizophrenia, paranoia, projection, blaming. So looking at racism as a pandemic, I favor the mimetic viral model where racism can be spread over the internet, over television, and depending on the mode can be absorbed if you don't develop your own protective immune system and be able to hold to the truth as you know it. Racism as a public health problem. So for example, if you use the environmental model of the public health system, basically strengthen the host, neutralize the agent, improve the environment. And one of the oldest recovery frameworks, because that's one of the frameworks that I use, developed by Frederick Douglass, addiction as slavery. So is as much a part of the gross domestic product of and the economy of this country and the infrastructure of this country as chattel slavery was. That is, it's legal, and it was legal to discriminate, legal to do rape and child abuse for your property, against your property. And that hasn't improved when we got so quote unquote free. Right? So understanding the pervasiveness of this problem and the fact that we can take steps to correct it.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
All right. Jocelyn, you're up.
Okay. So next, now that we've considered ACEs, we just like to look at what is it that we need from the patient-provider relationship. So, with ACEs in mind, knowing that, the provider is going to bring their ACEs and their, biases to the room, which is not your responsibility as the patient, but just acknowledge that, and that you as the patient are going to bring that in as well. So what this table looks at is looking at different types of relationships. There's social relationships, work-related relationships, and the client-caregiver relationship. So mostly will be depending on a client-caregiver relationship and the purpose, goals, and outcome of that relationship when we're looking at how we interact with our providers. So the purpose of that relationship should be to meet the client's physical and emotional needs, right? So that means when you visit your medical provider, whether it's your PCP, your psychiatrist, your therapist, you should be able to walk away feeling like your emotional needs have been met. So what are your priorities in that engagement? What are you coming into that patient appointment with? Maybe you just had death in the family, and that's something that comes up because it affects how present you're able to be. Maybe you just had a recent diagnosis of cancer or diabetes, and so you're coming in with that emotional baggage as well as needing to address the physical consequences and management of that diagnosis. The goals, similar to purpose, should be that your needs can be identified and that a plan is developed and put into action. So providers have all kinds of acronyms, and they're going to be looking at assessing you, doing a physical exam after they've done taken an HPI or gathered basically your medical history. And then there's the assessment and plan. So that's what this is talking about, is how they make a plan to address the medical diagnoses that have been identified. And then what do you want to talk about? So solutions to the problem and a plan to meet the patient's needs. So that doesn't necessarily just mean, what medication do we want to prescribe? What medications do we need to take this person off of? What types of labs do we need to draw? It could also mean, who do we need to get in this patient visit room to make you feel most in charge of your treatment plan? Do we need to bring in a partner? Do we need to bring in a parent or a sibling to help make sure you gather all the information and walk away feeling informed? Because often, if you've just been told that you have cancer or diabetes, that's the last thing you hear, and then everything after that is kind of the Charlie Brown voice. It's a lot going on. You start to kind of hear with blinders on because it's emotionally impacting you. So having somebody that can help you stay accountable and stay present and take those notes for you is great. And then what's the outcome? So clients' needs should be met, or patient needs really. Patient can develop coping skills and the patient can become independent. So a lot of these things are dependent, and this is just a generalization because you may be somebody that has a cognitive disorder, a developmental disorder, you may be somebody that has trouble advocating for your needs based on your ACEs and your trauma. So that's the optimal outcome, and we're not going to get that necessarily going to get that every visit, unfortunately. And so this whole session right now is about how can we approximate that more and more with each visit, and how can we feel comfortable advocating for ourselves.
Jocelyn, would you say a word about who you are?
Yes, sorry.
It's okay.
So I am a community service worker, community health worker with a dovetail program at Lane County Health and Human Services, as well as a second-year medical student. So I started to deal with some of these acronyms and intending to be a future family medical provider, as well as board in psychiatry. So definitely very passionate about this work. Thank you, Elaine. And then I can advance to the next slide. Okay, and so first to explain that language. So the language, the global majority, means if you are an ethnic or cultural minority, because by numbers, you're actually a majority if you look at the whole world. And I know in the United States, and I know in some smaller communities, it can feel, especially like Lane County, it can feel like we aren't a majority, but this is speaking on addressing your needs as a cultural or ethnic minority. So how can we do that in the patient provider interaction? So one thing we can do is acknowledge our individual and collective trauma within medicine. So this could mean if you are someone who is socialized as a woman, and if you're an ethnic or cultural minority, acknowledging what you're bringing to the table. So there are some amazing TED Talks out there on race and medicine and amazing books about it. But basically it's looking at, historically, medicine has been developed on the backs of the global majority in traumatizing ways. Obstetrics and gynecology was originally practiced and developed by horrific experimentation by J. Marion Sims on enslaved women that had vesicouterine abscesses. And so, looking at, are there traumas that I carry from my cultural and ethnic lineage, and are there traumas from my own experiences? And so some people may feel like they signed a waiver, and on the provider side, everything's clear. On their side, they still have questions. And so they're having these exams done to them, or shots given to them that they really aren't knowingly consenting to. So that could be part of your trauma, and acknowledging that you're bringing that to the room can help that next provider treat you even more consciously and try to make sure that you feel fully informed and fully welcome, and that the whole appointment is guided by your wants and needs in that moment. Prioritizing yourself goes hand in hand with that. So your needs should be met first and foremost. If it feels like they are stepping on you and you're trying to explain, I don't really feel comfortable with this treatment plan, or, I had a friend that followed this treatment plan and they got worse, and your doctor is just following their algorithms, or your nurse practitioner, your PA, whoever it might be, is following these algorithms and saying, well, I read in my textbook, yada, 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 so we have to do this. Patients don't read the textbook, right? So your situation may be totally different, and may be missing an important component. At the end of the day, medical providers need the buy-in of their patients, because the success of the treatment plan depends on your buy-in on it. So if you're not feeling like this treatment, if you're feeling like this treatment plan is not for me, you're potentially not going to adhere to that medication protocol. You're potentially not going to, take that antibiotic, take the antidepressant. You're potentially not going to, you're going to miss lab appointments because you feel like it's just an excuse for them to charge you something else, and you're not understanding why it's part of your treatment plan. So prioritizing yourself and ensuring that what the plan is being explained to the T. All this, everything is in language that you can understand. Another component of advocating for yourself is researching your symptoms and monitoring your body. So what that could look like is some of us may have primary care physician appointments, or primary care provider appointments, I should say, once a year. We have like if we're socialized women, we may have women exams, or we may have just a check-in every year. And then maybe as we get older, every couple years if nothing's wrong. And so tracking your symptoms outside of those appointments and monitoring your body can help you show up more presently at that appointment. Because I think often, if we're part of the global majority, we feel that we have to be quiet, we shouldn't ask for what we need, and we don't want to take up too much space. So you get in that doctor's room, and unless, you know, a limb is falling off or you're bleeding out and they ask what's wrong, you may just feel like, no, everything's fine, but it's not fine, you know? And so monitoring your symptoms and recognizing when you're not really living fully and not really feeling as well as you could, because those things matter. And it doesn't have to be that you have, you know, the latest thing is COVID, or it doesn't have to be that you know, are so that your diabetes is so exacerbated that you're, you know, expecting a limb amputation any minute to speak up in that appointment and say, yeah, I'm not feeling the best. And then, as I mentioned before, just taking those notes and asking questions in that interaction with your provider. And if you know of yourself that maybe you're someone like me that has pretty bad ADHD, maybe you're someone that doesn't feel like you know yet what to listen for in the provider appointment, bring someone along, bring a friend, bring a parent. It might behoove you to call ahead nowadays, because some clinics still have pretty stringent COVID rules, and they say we really don't want any extraneous folks in the visit room, and some places may be fine with you bringing 1 or 2 people. So just call ahead and make the accommodations that you need to show up fully, and have either yourself or someone else that can take clear and concise notes. The other thing is, don't let insurance companies dictate your health outcomes. So what that means is, if you are interested in, you know, naturopathic care, homeopathic care, if you're interested in getting a chiropractic adjustment, and that's something that you firmly believe is going to be, you know, the next type of treatment that's really going to help whatever your underlying condition might be, you have a right to that. So just because maybe you're on OHP or TRICARE or whatever it is, and they say, well, we can only cover this many visits a year and these types of treatments and these types of providers, and that doesn't fall in these, and we're going to make you pay out of pocket. Shop around. Maybe you need a different insurance plan. Maybe there are loopholes. You know, some places it's all about the language, and so it may not have a different line item that says, you know, you're entitled to a certain amount of chiropractic care, but it may say that you're entitled to a certain amount of CAM procedures, so complementary and alternative medicine, and that would be chiropractic, naturopathic, homeopathic, osteopathic. And then filling out that survey. So your feedback does matter, and you don't have to be, but you have the right to and can be, but you don't necessarily have to be that person that's, you know, writing a Yelp review for their doctor, or, you know, calling the clinic every day, but just filling out surveys or putting in your patient portal and calling, you know, the front desk and saying, this is the experience I had, I'd like to give feedback to somebody. That adds up and that matters. I've worked as a scribe before, and I've seen emergency medicine physicians that had enough scribes complain against them. Even it wasn't even the patient that they were reprimanded. So it matters how you're treated as a patient, and it matters how that provider treats other people. So if you feel like, hey, I noticed that the provider didn't really address my needs, was treating all the staff really, you know, miserably, and shouldn't be here, and it's clear that they shouldn't be in medicine, or at least not at the clinic that I'm going to, you have a right to speak up and say something, and your voice does matter. And then taking advantage of free screenings. So different organizations in the community, the NAACP, Trauma Healing Project, and some other sponsors will put out newsletters, or will send information to places like with my job with Lane County Health and Human Services, we get newsletters all the time. So then we can forward that information. And they'll let you know when there's a free screening event coming up in your community. Hiv Alliance is another organization that has a lot of free screening events that aren't necessarily even HIV related, just health events in general. And so knowing when those opportunities are available to you in your community is great, because you know, it shouldn't be that you have to pay a copay and do the most just to, you know, figure out, maybe have help tracking your symptoms. So maybe you don't have a blood pressure cuff at home, but you can go to Rite Aid to get your blood pressure monitored. Or maybe you, you know, don't have access to, or don't have resources to pay for a gym membership, but you learn in a newsletter that, hey, there's this place in the community that's doing, a yoga series that's going to be free to people of this, age group that I'm part of, or what have you. So I think acknowledging and staying abreast of what is free in the community is invaluable at this time, because healthcare is expensive, no matter how you slice it. So yeah.
Jocelyn, can we let folks know what the sounds are in the background?
Yes, sorry. I'm at the range today, so can't plan life, and I was needing to go to the range for my unit. So I'm not being shot at. I am safe, and I'm gonna have to be pulled off this call soon anyway. Hopefully no one's being triggered. Feel free to tell Susan or Elaine or somebody in the chat if that's the case, and I can hop off earlier. But yeah, it's intentional practice shooting, and not just random people shooting at me. So
You're serving your country in the National Guard?
in the reserves, Army Reserves.
Reserve.
Yeah. And I think we can advance to the next slide here.
There we go.
Perfect. Awesome. Thank you. So the last slide was, there's some overlap in the things that you can do, whether you're part of a cultural ethnic minority, as well as someone who identifies or is socialized as a woman. And so, but there may be some things that differ. So I wanted to kind of separate this out on another slide. So doing your research and shopping for your doctor, that overlaps, that's the same, you can do that. And you can also do that, I should say, if you're part of the global minority. I'm not trying to exclude anybody. Everybody's entitled to equitable, personalized health care that they choose. And then requesting accommodations before your appointment. So something I learned about recently from a friend of mine that suffered with eating disorders is that if there is something that you don't want to do, so for instance, you don't want to be weighed and it isn't medically relevant, so you're not on a cancer treatment protocol or having any GI maladies or anything where you would expect to be losing a lot of weight or gaining a lot of weight, and that could be, indicative of, okay, now the cancer's metastasized, or now something's really wrong because this person lost 30 pounds without trying, or they gained 30 pounds without trying, then you can refuse to be weighed. So you can let your provider know, so that when the nurse comes to get you before the provider goes in the room, or the medical assistant, I don't want to be weighed, please have that put in my chart. It's going to be too triggering for me. And if I feel like being weighed, I can weigh myself at home, but I don't want to be weighed in this public setting. And they cannot weigh you. So if you advocate for those needs, it's your right, and they are not allowed to go against those rights. And then bringing notes. So like I mentioned on the last slide, taking those notes and then bringing them to subsequent appointments, because if you're depending on an EMR or EHR to be up that day, you're going to come on the one day that it's down. So I think just having that backup, because you can't always depend on these electronic systems to be perfect, and for providers to log their notes efficiently, and then for it to carry over to every system. So there may be some clinics that you visit that are outside the EMR system. And then listening to your body. So you may go to a provider that runs their tests. They think they know what they're doing. They've been told to look at this certain algorithm, and if you have symptoms outside the algorithm, then it's in your head, or, well, it looks fine, but listen to your body. If you're uncomfortable and you're having pain that just can't be reproduced in the appointment for one reason or another, like maybe it's fatigue and pain with walking, and you're having more trouble breathing or something, or it's, it hurts when I move like this, but they've done all their tests and, they can't re-elicit that pain in your shoulder or whatever it is, that doesn't mean that it's all in your head. So bringing your notes, advocating for yourself. And if you have a provider that tries to chalk it up to it's all in your head, or like, you say, oh, it's pain like when I go like this, and they do the test and everything's fine, and then their advice is, well, just don't do that. Then you won't be in pain. No. Advocate for yourself. Something's wrong. You could have in that example, you could have a rotator cuff tear that for some reason is not, inflamed that day. So advocate for yourself, get a second opinion. Leaning on your support system. So we talked about one element of that, which would be if you want to bring someone in the clinic room with you to take notes, but that could also be outside of the appointment itself. So afterwards, if you are still processing, being told you have a certain diagnosis or being treated a certain way by a provider, sometimes leaning on friends and family to talk about it with can not only destigmatize some of these conversations and generate rapport by letting that person in that aspect of your life, but I think there may be another person that's having those same issues with that provider or with that hospital system. And so being able to talk about that may help you realize, oh, there's something wrong here. Like other people aren't getting appropriate care by this provider, or other people have been touched inappropriately by this provider, or whatever it is. So having that conversation to bring those things to light. And don't settle for treatment you're not comfortable with. So there's a really great documentary called At Your Cervix. And it's about how there's something called MUTAs and UTAs, and they're GTAs and MUTAs. So they're gynecological and male urogenital teaching assistants, so that some hospitals now have actual people instead of the plastic dummies that medical students and providers in training can train on to do gynecological and urogenital physical exams, so they know, hey, this feels right, hey, this doesn't feel right. And it talked about how people would be going under, in this documentary, under for GI appointments, and they would be having students that were walking through the hall be doing genital urinary exams on them or obstetric exams on them against their permission while they were under. And so that happens some places. And if you wake up and you feel like something's off, this part of my body hurts and that wasn't part of the procedure I went on. Or if you go somewhere and they're saying we have to do this, that's part of it, and you're like, I'm coming in for stomach pain, like I don't think I need a obstetric exam, I don't think I need a bimanual obstetric exam. Stand up for yourself, don't let providers just run up charges and do things that you don't feel comfortable with. And then getting that second opinion and coordinating your care, as I said before, that kind of go hands in hand with taking those notes from provider to provider is the coordinate your care part, and getting that second opinion. So if somebody's making you feel like it's all in your head or there's nothing we can do for you, there's something someone can do for you, and just finding that provider that is willing to do the work. And then filing the formal complaint if you've been mistreated. So like I mentioned, if you feel like there's providers that are doing bimanual obstetric exams and you're in for something unrelated, or there's providers that are doing breast exams longer than normal, or touching in ways that don't feel comfortable, you can file a report, and you can file a formal complaint if it just something feels off. It doesn't have to be as egregious as inappropriate physical touch. It could be they're talking to you in an inappropriate manner, they're treating you harshly, whatever it may be, because they could be doing that same thing to somebody else. And then I think on the next slide here, we talk about also, as gender minorities and LGBTQIA. Oops, I got stuck in advanced. So similarly, if you're LGBTQIA or a gender minority, this would apply to those social as women, but as well as some of the other gender minorities. A lot of the same things apply, but also knowing your legal rights. So unfortunately, not everywhere has providers that have treated and are passionate about treating LGBTQIA plus members of our community. And so knowing your rights when you go in, trying to find, if you're looking for gender affirming care, if you're looking for somebody who can give you more pointed advice about certain aspects of your health, it's important to find that. I remember I identify as bisexual, and I remember going into a provider who was asking me all these questions about why I was asking for birth control, because I was with my now fiance, and said, well, forgive me if I don't remember correctly, but I thought if two women had sex, they couldn't get pregnant. First of all, that's not why I want the birth control. Maybe I just don't want to, maybe I want to skip my period. Like, nobody asked you all that. But so I think, being able to advocate for yourself, because you are going to have people that were educated in an antiquated system of health and are totally just not in the loop, not informed, and don't know how to treat any patient that isn't an older white male that still shows up to the doctors with no tattoos and in a suit because it's a formal event. And if it's anybody else that looks any type of different, they don't know what to do. So advocate for yourself in that regard. And then it may be you want to bring someone with you, not because you feel uncomfortable taking notes, but maybe you comfort on that provider, or maybe you feel like that provider insists on naming you or using the wrong pronouns. Somebody who has that collaboration. And then educating your providers, you know, maybe there's somebody who's open to it. About situation want to do it, want to do the right thing, want to do the right thing.
Jocelyn, your audio is breaking up. Did something change? Are you moving or something?
It's better now. It's better. Can you hear me now?
Yes, it's still a little distorted.
Okay. I may have coughed here since the reception out here on the range isn't great. Educate providers, find community of patients, so communities any kind of like transponder, and they find folks that will help you advocate for yourself, as well as finding support. So you have to go to providers, have to be anyone before, go to the provider to get support for you. That's all I have said.
If I may paraphrase, the part that did come through where if you're gender non-conforming or gender minority LGBTQI, there are culturally specific resources like Transponder having a list of providers that we talked about in the previous seminar. So that's it. You saluted?
Hand over to
I hope the Army isn't jamming us.
go on to the next slide. And
Okay, TC, you're up.
Yes. Much of what much of what Jocelyn said, and I really appreciate Jocelyn for actually going through all that she had to be here today. And I appreciate what she shared, and a lot of it has to do with what I will be talking about. I'll be talking about advocating for yourself as a senior and elder, and advocating for yourself as a person who has been labeled someone with a labeled mentally ill. Do you have that slide? I can find it here. So what I've done is I've put together some things, you know, some extra things about how to advocate for yourself as a senior elder. Seniors do not, you know, in our society, they do not automatically just, you know, start getting better care or start getting their needs met just because they're older. And they also, even though they end up with more needs as they, you know, health needs. So what I have come up with is some of the main things I thought is that seniors need to know that they know themselves better than anyone. They know themselves best. And a lot of times that what they think they know about themselves, then they have to actually go find out really what they really believe and who they are and what, what their likes and desires are, because usually that they aren't really, they're told basically, or they get used to thinking that they are something or like something, or because they've been told so much that that's what they like and that's what they are. And so it's a time to evaluate who you really are. What do you really like? What do you desire? What are your hopes? What are your fears? And to share those with people. And so now is that time. And it will help in the patient-provider relationship, because they will see you as you are, and they can help you better that way. And I said, you own your voice. You can share what you desire. You can be open and clear and honest, and you should be able to. I guess these are things that I think in a relationship where a person you're with a trauma sensitive provider, then you would hope that you would be able to do this, that you would be able to be honest with them. You'd be able to tell them, pretty much whatever you thought that they needed to know, and feel like you wouldn't get judged for it or put down for it or treated differently. And I said, you are worthy of the time spent. So expect that time and come prepared to use that time. And if you don't get your needs met that you had thought you wanted to accomplish, what you wanted to accomplish in that meeting with the provider, then make another appointment, because you are worth it. And you're worthy of all the time spent, anytime that is. And the other thing, you can make choices about your treatment without pressure. You should be able to in a trauma-informed society, and without pressure. And oftentimes seniors are pressured by relatives and by others to do certain things, to have certain procedures, or to not have certain procedures. And yet they are the ones who have to endure whatever happens. And they know like what they want, how this is going to affect their life. If they're going to, say they want to go on a trip and their relatives are saying, well, you need to have, this happen now. And so they tell the doctor, and so they make arrangements without the person's saying so, that that for that person to have that. And so they miss out on, for instance, like maybe taking the trip of a lifetime that they've been wanting to do for a long time. And so it's good to be able to know that you do not have to make choices that you're not comfortable with, or that you want to put off, or just don't feel pressured into it. And you should be able to share the power. There's usually power differentials in relationships where one is considered an expert and the other is not considered an expert. And know that you are the expert. You should have equal power. You do have that power, but sometimes it's not evident. And so you just go in assuming that you should have that power. And so you can make requests, you can make demands, you can tell, you can say yes or no to anything that you want. And this is I'm talking like in an ideal situation, an ideal world where people were trauma informed, and where patients were at that point where they could speak up to their doctors, and they could tell them, I want this, I want that, or I don't want to do this and I don't want to do that, because in reality, we're not there yet. So, and advocating for yourself as someone who with a mental illness or labeled mentally ill is pretty much the same, some of the same things. I think, it's important to realize that you're the expert. You know your experiences, you know how they make you feel, the effect, how they've affected your life, how they've impacted your life in the past, how they have now. And you can share that, and you should be able to share that with a professional. And let's see, I'm just going to read off here because I don't have the slide. So I'm just going to read some of this stuff. And then if you are the expert, okay, plan ahead of your crisis to ensure your voice is heard. A lot of times things happen and then it's too late for you to say, you know, how you want something to happen, whether you want to be, you know, injected with a med, or whether you want to be isolated or thrown in a room or whatever. So plan ahead, let someone know, let everyone know that, you know, this is what I want. This is what I don't want. This is what I like. I don't like, you know, bright lights or whatever, just everything, just have that ahead so that when you are in crisis, then you can have done to you, or you know, you can be treated respectfully and have your wishes considered. And then searching for and utilize peer support and other advocates for support with your provider is very important. It's one of the things that has been important when they start talking about trauma informed care. Then one of the things that has come out is that others who have been there are really some of the best able to help someone else who has those same issues to move towards healing. And choose the direction of your appointment stated at the beginning. When you go into an appointment, say what you want to get out of that appointment, and you know, stick to it, and then just, you know, if you can't get everything said or everything addressed at that appointment, make sure you keep being persistent and bring it up. Don't let time constraints get in your way. And then you have the right to share in decisions about you. Many times, patients, people diagnosed mentally ill are not able to share in decisions. They are not given even a choice or even asked about decisions. A lot of decisions are made about them, but know that you can share in decisions about you, and that maybe you might need to go to someone like a peer support person or some other you know, agency that advocates, like the ADRC, to be able to to be able to get some support and to know, you know, and get some help in getting your needs met. And you could say, and you should be able to say no or disagree without fear of retaliation, and not expect that compliance shouldn't be expected of you. But you may need assistance with that, usually because most people are, because the reality is that there is a retaliation at times, and there is an expectation of compliance. Not so much now, you know, in these years. I think times has changed, so not as much now. It's not, you know, the biggest thing, but it used to be primary, and it's still there, though. There's the kind of sometimes it's, I think, a threat, like a threat of retaliation is there and embedded in most things. Or if you don't comply, then this is gonna happen to you. You're gonna lose your housing. You're going to, you know, not be able to be in this program, not get your money, whatever. So, but there are people out there, advocates, who will help you so that you don't, that you can still get your needs met. So the next slide, please, since you found it. Okay. So everyone in the best situation possible, the best world possible, everyone should should be able to feel safe, to feel valued, and to have power in a real world, and to be, as we move towards trauma-informed approach more, then I think that we should see more of these things. So when your relationships with your provider, look for how these things make you feel, and maybe that's, you know, maybe that's not the provider. If these things aren't there for you and aren't evident, then maybe that's not the provider relationship that you need, and maybe it might be better to try to find out how to adjust that relationship or move on to another one. So in my estimation, I think a trauma-sensitive provider is one who, you know, it is all constantly making progress, you know, because no one's totally there. You know, no one's arrived at this perfection of being, you know, the greatest helper or the greatest expert in whatever of another person. And so they're constantly progressing. They start using, you can judge, they use words like you and your more than the words I or my. And those are, you know, usually, you know, I, you know, like they say, well, and how, and also how they avoid, how are we today? And I'm sure a lot of people have heard that expression. You know, you go into a room and it's just you, and they say, how are we today? And you're the only person that walked in. And then the expression, it's like reminders that I am the doctor, you are the patient. And so, so that's, you know, those are things, you know, that shouldn't be in a, you know, that hopefully we can try to get rid of in our relationships. I think that they also try to learn from the patient what happened to the patient. What happened to the patient becomes more important than what is wrong with the patient, you know, with the goal of, I'm going to fix you. I want to fix you. It becomes more, what happened to you so we can work together and, you know, tell me, well, you know, we could see like how we're going to direct our time together, so that you can get the most out of this, and so that I don't re-traumatize you and all that. And let's see, and they avoid the compulsion to label upon sight. So they see you walk into the room, and maybe just by what you wear or the, you know, the way you look in some kind of way, or ethnicity, whatever, then they perceive, then they say you're schizophrenic, you're a pill seeker. You know, maybe you have your head a certain way, I don't know, but just by not judging, not labeling, just when they first see you, or just when they don't know enough of anything about you. And that's just goes with same with, you know, walking into the room alone rather than with the whole group, and yet you're categorized in their mind as, you know, because when they see one person walk in, you're gays, you're Mexicans, you're women, you're teenagers, and all that. And so with that, all that does is just further stereotype and re-traumatize people. And it doesn't see the person as an individual. So they can't be valued, they can't feel safe, they can't feel that they are empowered at all. And that equipping and empowering the patient is very important. It's one of the things that is going to help the patient to remain as resilient as they have been, because if they, most people who have mental health diagnoses are probably the people who have been through probably a lot of trauma. And so they have shown their strength. They're very strong people, I think, very resilient. And so the trauma-sensitive provider will help them to remain that and encourage that, and it'll flourish. And then I mentioned already that they give up the urge to pressure or force a person into compliance, a patient into compliance, and that becomes not important to them. It's not of primary importance, but rather the patient themselves and what they need is the most important. I think here we were going to tell our personal stories. I think Jocelyn and I were. Jocelyn, are you there?
She's not. I'm
Okay.
starting to, I think that both of you kind of did a really nice job kind of highlighting things. I'm just wondering if Mark has a thought about where to move the conversation now. You're muted, Mark.
Okay. One of the things that you can hear me now?
Yes.
Part of the in making yourself stronger and also advocating for yourself, I like what both Jocelyn and TC were talking about in terms of you may identify as something that your provider wasn't trained for. So both educating yourself and making yourself safe, and there's a certain degree of educating your provider, but a progressive provider already knows or is already open to that education by, experts can still learn. They're always continuously learning.
That's the sign of a true expert, a true trauma sensitive person. They are forever learning, and they have not arrived. They know they have not arrived, and they're continuing to learn. They're continuing to get support themselves. They know that they haven't arrived. I think that that's one of the things that really makes me really happy is when I see a provider who is able to go to someone else and admit that they go to someone else to get help for themselves. So,
one of the things that gives me hope, especially with the example of Jocelyn being a second year, also in the military, also delivering this great talk, especially under fire. Not that they were shooting at her, but yeah, it was an interesting juxtaposition because a lot of times it's almost a flip of what you said. It's not what's wrong with you, it's what happened to you. And there's no diagnosis for systemic trauma that, how do you make a sane adjustment to a situation that's insane and been normalized, but didn't destroy you?
mm-hmm. Yeah, I think in my experience, I think that for a long time in my life, because I've been a part of the mental health system, since I was 18 and I'm 73 now. And I think that a lot of times until like recent years, I didn't even understand what was going on with me or what was happening. And I found out in recent years after trauma therapy that it's really more about trauma than anything else and what happened to me, not what's wrong with me. And as I was going on the basis of what's wrong with me, I think that since that's what I was going on, I thought all this stuff was wrong with me. And that's what I focused on. And that's what everyone focused on, is what was wrong with me and trying to fix me, doing all these things to me, like shock treatments and medications and things that, weren't helpful, changing my diagnosis every, couple of times, every time. And it's just like, it wasn't helpful. But then really understanding, when I was able to understand what was really happening with me and what had happened to me was important, and that I could talk about it, and that it was, and that I needed, that it was something to be dealt with, not to be hidden or shocked out of me by, electroshock.
I found I had maybe an ACEs score of 1 or 2 because ACEs focus mostly on sort of like family dysfunction, but not social dysfunction, right? So
Right.
my first racial attack was in Disneyland in 1962, where you could smoke in the park at the time in Anaheim, and this white guy put a lit cigarette in my hoodie and then walked away. And my uncle noticed it and stripped off, the the garment and put it out, and it just started smoldering, but no danger of catching fire. And I went on with the ride, but later that night, my parents let me know about Emmett Till because they saw it as a racial attack, right? And so imagine my romper room mind. This is definitely dating me. My romper room mind, because it's too early for Sesame Street, but my romper room mind trying to wrap around the fact of lynching, right? And my experience, for example, in Eugene, where when I would relate, talk about Emmett Till in the 50th anniversary, so 2005, 2004, there was a PBS special. I was told that didn't happen by a counseling organization that basically referred to an African-American family as being in a tar baby situation. And wait, no, that's an ethnic slur. You can't use that in therapy. And maybe I should. What do you mean why would I make up Emmett Till? So being in denial that racialized trauma existed and that it could happen in Disneyland, which, you think, well, from Black history, the main street that Disneyland portrays, Black people weren't allowed to walk on the sidewalk. So even though I began the broadcast talking about, hey, we couldn't even walk on the own property in the streets of Eugene at all, right? And so people have this idea that, oh, he's so progressive and it's always been that way. But no, we have these things that happen that are commonplace that society's in denial that this stuff happens, and we have to basically find our own definition of sanity.
Yes, I believe that too. I think, unfortunately, I think that people there is a lot of denial around, racism and, and that, but I think that even though there is still racism persists, even in Eugene, then I think that, we have to, there are some people who are trying to change that. And so we can't just totally just say that nothing is happening here, or that there are no changes or no people are trying to alter that. And, the ACEs study, no, it does not consider, it's more about the personal, social things like that. But yeah, there's, I think that eventually we're going to have to, if we really want to change the whole thing with race and just, then we'll probably have the racial trauma, intergenerational trauma, historical trauma, and all that. We'll have to look at the, look at those and just see how people score there. And it's not just keeping score. And that's the thing, is that the whole ACEs study shouldn't be about, keeping score and marking off something on a checklist. It's not, shouldn't be the goal or the main things, just trying to make changes, actually. That's what we need to do.
Make changes and kind of growing stronger, bring more practice, especially in the micro resistance arena, because it can be one of the things that gives me hope is, people like, younger people like Jocelyn who, going through their military experience, going to go into psychiatry.
Yeah.
I really like that her slides may have been cool, but she spoke fire.
Yeah.
So that's great to be able to articulate that and carry it forward. And say,
Yes.
no, I'm not angry. We're not angry Black people. We're just saying, yeah, this isn't quite right. And even though this racism is aimed at us, you're suffering too.
Exactly. We all suffer
Yeah.
because of
Mark,
it.
Yes.
excuse me, this is Susan. Siobhan has her hand up.
Okay.
Thanks, Susan. Hi, my name is Siobhan. So one thing that came to mind when you were talking about this is I take Advair every day to live. It's a breathing medication, and they don't make a generic version. And so I had to fight with my health insurance for about a year, trying all these different medications, from things for COPD to like just stuff I didn't have, in order to prove to them that none of these medications would work. And in the end, I was having so much trouble breathing in the interim that I ended up getting rid of my health insurance so I can go back on the patient's assistance program, because as opposed to paying $300 a month for this life-saving medicine, I'd rather pay the $200 to go see my primary care physician. And it's just like, that struggle it just blows my mind. It's like, I need this to live and I can't get access to it.
Yes, that's one of the systemic things that we have to, well, not just we have to negotiate, but a lot of people have to negotiate, where these meds that they may or may not advertise on television that don't work for all of us, but are the only ones offered, and there are adverse side effects. So definitely not, and we're not necessarily being told that by our providers, who basically just prescribe them mostly because it was a drug detail person that sold it to them. And, you know, I feel for you.
Siobhan, can I,
Go for it.
Siobhan, I just wanted to note that, you know, it sounds like you were advocating for yourself the whole way through, and you were still hitting walls. And, you know, it's not a great solution what you ended up doing, but you did find ways to negotiate the system. And you're sort of doing that sort of dual thing that Mark mentioned in his slides. You know, you're facing the sort of microaggressions, the impact on your health, and you are negotiating and staying present and fighting for your own care. And it shouldn't have to be like that, but it certainly would be worse if you weren't doing that for you, it sounds like. So I just want to acknowledge that that's kind of kick ass, and thanks for sharing it.
Yeah, that's great, Siobhan. I hear a lot of people with the same thing that you're dealing with every day, you know, just with the financial, trying to decide on, you know, how to pay for their meds, where to go, or what their insurance will pay, or getting the meds that paid for that they really need or want, and maybe the insurance doesn't want to pay. And it's just really frustrating that it comes down to money most of the time, or the, you know, the lack of money or whatever, and insurance companies or pharmaceutical companies or whatever, and, you know, that a person has to rely on to have good health care.
Yes, and if I can just add, one of the reasons I was able to do all that is because I have a good provider. I was raised in a family of doctors. I have advocates on my side, so I had a lot of help. But even with a lot of the stuff that you mentioned today, I was still, I mean, unsuccessful in going the systemic route.
Yeah, it happens all the time. It's sad.
Yeah, even I mean, and on my reading list, actually it's an audiobook for me, but Under the Skin, talking about the, you know, experience of Black people who are well educated, who are well off financially, experiencing low birth weight babies, maternal mortality. I think about, you know, the experience of Serena Williams in her birth experience, the Black female doctor during COVID who was she's a doctor, she's trying to advocate for pain medication and basically is denied that because they see her as a drug-seeking Black person, not a and a patient, non-compliant patient, not as a fellow suffering professional, right? Just because of her excellent suntan. So yeah, you definitely did have a kick-ass response. And even given all the advantages that we may possess, still things can go wrong.
Mhm.
The fact that you were having trouble breathing through the whole thing. Yeah, you're amazing.
I just hope that these seminars help other people get that confidence, because I mean, a lot of us, at least the people that I speak to, don't want to go to the doctor. They feel like either that's where they'll get sick, or, you know, it's a lack of knowledge, or they feel like they won't be heard. And it's like, we still need care just like everybody else.
Yeah.
Well, I feel that that the information is accessible, but we definitely have to take our own education, our own medical education into our own hands, because you can't necessarily rely on medical school to give that to you. Even though you might get the latest science and stuff like that, it may not necessarily come to your advantage if you become the patient. But arming ourselves with information is better than ignorance.
Julie's got her hand up.
Go ahead. You're muted.
You're muted.
Your microphone may not be connected properly. You could put it in the chat if you wanted to, if it's, yeah, sorry.
Julie, are you broadcasting from a phone or a computer?
I think she's trying to write it in the chat. While she's doing that, I know we're getting close to time, but Siobhan put in the chat, we need to talk to one another and help each other understand also. So
Yes.
that really needs to happen. Mhm. Julie, are you still trying to put something in the chat? We still can't hear you. She is, yeah. Is there Mark or Susan? Is there any? That's a good question. Oh, she's trying to figure out how to turn on the microphone. You know what, Julie? Without seeing your system, I probably can't help you. And you're. Oh, now you just did it. You're connecting to audio. Hang on. Let's give her. Shall we go over 5 minutes, everybody, and we'll all quit in about 5 minutes? Is that okay? Just so we don't cut people off.
Yes, let's hear it.
Julie, it's trying to connect. You just have to say yes, connect to computer audio on that little menu. Tell it, yeah, there you go. Now we should be able to hear you. Nope. You tried. I'm sorry, it may not work today. Now try, Julie. Oh. Mark, Susan,
Yes.
what would you like to do with these last 5 minutes?
Well, I'm trying to put it in the chat and I'm having trouble with my chat feature, so I'll just say it out loud. While we were in the webinar, I chose the 3 winners for the gift card. I did a random number generation. And the winners are, this is a $15 Visa gift card that we will send to you. David Oakes, Kathleen Jonathan, and Julie Carter. And I have your email addresses, so I will send you an email. I'll connect with you whether you want a virtual or a physical card. So I'll be in touch real quick on this. Congratulations and thanks for coming.
My machine says you're unmuted, Julie.
I can hear you.
Oh,
Cindy, you can hear Julie?
I can hear Mark.
Oh,
Oh,
right.
yeah.
Hmm.
Yeah, but we can't hear Julie.
Yeah. Hmm. It says she's unmuted.
yeah.
It does. There's just a disconnect. Julie, if you wanted to stay, I could help you a little afterwards and we could see if we could figure it out, just so that doesn't happen to you again. Any last words from anybody? Before we say bye?
If your gut tells you something's wrong in a doctor's office, listen to it. It's probably right. And if it means going to get an advocate, or help finding someone who can go with you. I think if any of my friends came to me asking for that, I would say, yes, in a minute.
Mhm.
Yeah.
We have to take care of each other.
Yeah. Yeah, friends can make good advocates and family. They can, sometimes you have to train them a little bit so that they let you be the person who is the speaking for yourself, but they can be good advocates.
And for experience in my past, I think often having an advocate there will make the physician shape up.
Yeah.
It
Yeah.
can.
I'm wondering if Allison or Kathleen might want to say anything before we say goodbye. Or David. No. Just want to make sure we make space for you.
Well,
Thank you.
a motion to adjourn is always in order.